Welcome. My name is Barry Kramer, and I'm the Associate Director for Disease Prevention in the Office of the Director of the National Institutes of Health. I'm very pleased to say that this is the 15th year that the NIH Gordon Lecture is being awarded. When the lecture was first established, the word annual was not even included on the publicity posters, thinking that maybe we would not be able to maintain enthusiasm over the years. But if you look at the back of your program, you'll see that the NIH has bestowed this honor on a prestigious scientist each year since 1995. The Robert S. Gordon Lecture in Epidemiology is awarded to a scientist who has made major contributions to research or training in the field of epidemiology or in the conduct of clinical trials. The recipient is selected based on the advice and recommendation of senior epidemiologists at the NIH, and the award lecture is sponsored by my office, the Office of Disease Prevention. The Gordon Lecture was established in 1995 in tribute to Robert Gordon for his dedication to the field of epidemiology and his distinguished service to the National Institutes of Health. During his more than 30 years of service to the NIH, Dr. Gordon served in numerous senior leadership positions, including as special assistant to the NIH director. He was chief advisor for clinical practice and research to 2 NIH directors. Dr. Gordon was also an early organizer of efforts to address the emerging problem of HIV/AIDS and became the key NIH coordinator for AIDS research. For the last 10 years of his life, Dr. Gordon made important contributions to inter-institute policy and management issues regarding epidemiology, clinical trials, and the health effects of environmental hazards. The Robert S. Gordon Lectureship is therefore named in honor and in memory of his distinguished career and unique contributions to science. This year's recipient of the Gordon Lecture Award happens to be my dear friend and professional colleague, and introducing him this afternoon is therefore a particular pleasure for me. Dr. Leon Gordis is Professor Emeritus of Epidemiology at the Bloomberg School of Public Health at Johns Hopkins University, and Professor of Pediatrics at the Hopkins School of Medicine. He is also a visiting professor at the Tel Aviv University School of Medicine and School of Public Health. Dr. Gordis has made immeasurable contributions to several fields of science during his long and illustrious career. He is a world-renowned scholar in epidemiology and pediatrics, as well as a leader in the study of evidence-based medicine. He has served on many national task forces and advisory committees to examine scientific evidence, develop guidelines and recommendations, and establish clinical standards of care. In fact, I first met Leon when he served as the chairperson of the NIH Consensus Development Conference panel on mammography in young women, held in 1997. It's been my privilege to count myself as his friend and colleague ever since. Most recently, he was selected as chairman of the Monitoring and Oversight Committee of the National Children's Study of the Eunice Kennedy Shriver National Institute of Child Health and Human Development. Dr. Gordis is widely published and has been on the editorial board of many scientific journals. He's also the author of several books, including Epidemiology, now in its 4th edition, which is considered an essential reference and one of the most comprehensive, widely used epidemiology textbooks. During his career, Dr. Gordis has received many honors and awards, including election to the Institute of Medicine in 1986. Even with all of his accomplishments, Dr. Gordis takes greatest pride in his role as teacher and mentor of future generations of epidemiologists. He's taught epidemiology at the Johns Hopkins School of Public Health for 32 years and in the School of Medicine for almost as many. From 1993 through 2006, he also directed the Robert Wood Johnson Clinical Scholars Program at Johns Hopkins. Having trained more than 17,000 graduate and medical students, Dr. Gordis is widely considered to be an extraordinary mentor and role model by students and peers alike. Even after over 30 years of teaching, his lectures have lost none of their verve, as you are about to discover. For 6 years, his students in the School of Public Health have bestowed on him the Golden Apple Award for Best Teacher. In 1992, he received an honor from his peers by being given the Maryland Association of Higher Education's Outstanding Educator Award for exemplary service in post-secondary education. In 2007, he was honored by the Johns Hopkins Alumni Association with an Excellence in Teaching Award. The subject of today's presentation is the role of epidemiology in the development of health policy. This issue is of interest to a very broad audience of researchers, clinicians, and public health professionals, and is a frequent topic of debate whenever government bodies or policy leaders make decisions that they claim to be based on the best available evidence. Dr. Gordis will discuss some of the challenges that arise in using epidemiology for the purpose of developing health policy. He will also talk about uncertainty as an issue that must be recognized in the translation of the results of epidemiologic studies. Finally, Dr. Gordis will present some of his thoughts on how the scientific and societal relevance of epidemiology can be maintained and strengthened in the coming years, both in training and in practice. I'm delighted to introduce Dr. Leon Gordis as this year's recipient of the NIH Gordon Lecture Award. His presentation is entitled Epidemiology at the Interface of Science, Policy, and Politics: Are New Directions Needed for Epidemiology Training Today? Dr. Gordis will speak for about 40 minutes, and then the audience will have the opportunity to ask questions, both here and afterwards. As you may be aware, there's a reception out in the lobby, and we invite you to continue the dialogue with Dr. Gordis then. Please join me in giving Dr. Gordis a very warm welcome. Leon?
That's very sweet. Thank you very much. Thank you very much, Dr. Kramer. It's a pleasure to be here, and I'm very appreciative to Dr. Kramer and the other members of the awards committee for bestowing this honor on me, and I thank you all for coming. I had the pleasure of knowing Dr. Gordon, who was a student in our department. It was somewhere, I guess, at midlife point, where he came to talk to me about wanting to learn more about clinical trials. And he wasn't interested in a degree. He just said he wanted to take the courses that interested him, which I thought was very noble. But I still tried to convince him to take a degree if it didn't mean distorting his program. And that's what he did, and received the master's in epidemiology for his clinical trials work. He was a person who was really deeply committed to the future of epidemiology, and was a firm believer in its importance and the importance that it could contribute to public health areas. Now, I'm going to talk about a few topics, and I'm convinced that many of you know much more than I do about each of them. There is a story about a fellow who got up to lecture, and he said, my mentor told me that whenever I get up to lecture, I should always remember that there's one person in the room who knows more about the topic than I do. So before I start, I'd like to wait and ask that person to please get up and leave. Okay? So that's sort of the way I feel today, but hopefully we'll still have some interesting discussion when it's over. Now, I'm going to start with just two examples, one of which Dr. Kramer has mentioned today, and they're both in the area of screening, just to give you a feeling for how complex and how many disciplines are really involved in each of these issues we face. And I'm going to make them very brief discussions. The first is the issue of mammography, and as Barry mentioned, I had the pleasure of chairing the NIH consensus panel in 1997. So the bottom line of that is that you would think if that was 1997, it means that the issues have all been resolved by now. So that's the point that I'd like to address. Now, here we have a quick chronology going back to 1987, when the Cancer Institute adopted working guidelines to begin screening by age 40. And those guidelines in 1989 were officially adopted by leading cancer leading cancer organizations. And in 1993, the Cancer Institute then changed its recommendation, saying experts do not agree on the value of routine screening mammography for women ages 40 to 49. The American Cancer Society and 20 other organizations disagreed. And because of this and other factors, a consensus panel was set up to discuss this issue. For those of you who are not familiar with the process, at least the process as it worked then, the director of an interested institute puts in a request to the Office of Medical Applications of Research and asks to have a consensus panel address what is a controversial issue. This was the program of the meeting at which the panel weighed the evidence. You can see this woman is sitting in sort of rustic relaxation, contemplating life and whether she should have a mammogram. So we thought, at least I certainly thought, that this was my fourth panel, but the first one that I had the pleasure of chairing. And I thought it was going to be like a seminar at Hopkins. You know, we listen to the evidence and we have a nice serious discussion and everybody walks out and very polite. Well, it didn't quite turn out that way. And I could go on for the rest of the hour showing you headlines from various journals and publications, but I won't. And what I want to just show you is are the findings, but really the recommendations of the consensus panel, which is summarized in this slide. And the panel concluded that the data currently available do not warrant a universal recommendation for mammography for all women in their 40s. Each woman should decide for herself whether to undergo mammography. Her decision may be based not only on an objective analysis of the scientific evidence and consideration of her individual medical history, but also on how she perceives and weighs each potential risk and benefit and how she deals with uncertainty. And she should have access to the best possible relevant information to help her make the most appropriate decision. And the panel also specified that for women in their 40s who choose to have mammography performed, the cost of mammograms should be reimbursed by third-party payers or covered by HMOs. Now, it got a lot of press, and this is from the beginning of an article in the New York Times by Gina Colada. And I'm not going to show you the whole article, but just some excerpts. Dr. Richard Klausner, as director of the National Cancer Institute, had asked that the panel be convened, rushed to the hallway to use a public telephone. You can tell that it was pre-cell phone days. Okay. After Dr. Gordis read the statement, in an interview there, he said he was shocked by the conclusions, adding that he disliked their negative tone. It's always been a puzzle to me how he could be shocked when he asked to have the consensus panel set up. He said an advisory board to the Cancer Institute, that's the NCAB, would review the decision next month. Now, people who were not at the meeting have also chimed in. Dr. Bernadine Healy, Dean of the College of Medicine at Ohio State, former director of NIH, said that although she had not read the report, she was shocked by the panel's conclusion. It reminded me of high school book reports that some of my children write. Quote, "I'm very disturbed that a group of so-called experts challenge the notion of early detection," she declared. "What they're saying is that ignorance is bliss." And this was the summary in the newspapers of what they thought the impact of Dr. Klausner's intervention was by expressing his criticism midway in the process of getting consensus. Now, here is the interesting point in this story. At the time of the press conference, CDC means the Consensus Development Conference, he said, my own view is there's benefit in terms of mortality. So he disagreed with the panel. At the regular monthly meeting of the Cancer Advisory Board in February, he said, we cannot create certainty where it does not exist. 1 month later, March 27th, he said, women in their 40s should be screened every 1 to 2 years with mammography. And I want to assure you that between the time of the two NCAB meetings, even if I had put in the T, between the times of the two meetings, there were no new data to bear on this question. So something had happened to motivate him to change his mind. And Dr. Barbara Reimer, who was chair of the NCAB, in February she said, we'll not be able to say the exact age at which a woman should start mammography. We'll not be able to say how often she should get mammograms. It's not going to be as simple as you would like. And 1 month later, she said, for women 40 to 49, it's prudent to have mammograms every 1 to 2 years. So what we see here is the effect of political considerations and how it can even change the recommendations of the organization asking for an advisory committee to advise and then basically disregarding it. The story is actually much more interesting, but there's no time for it today. Now, you would think that would settle the issue. Now, here in 2007 is a postscript from the American College of Physicians that published guidelines screening mammography for women 49. And what they wrote, and I don't want to read you the whole thing, is that evidence indicates women to 40 to 49 who undergo routine mammography will decrease their risk for deaths due to breast cancer, but will increase their risk from undergoing unnecessary procedures, breast cancer-related anxiety, discomfort, and exposure to low-dose radiation. Because the incidence and effectiveness of mammography are lower in women in their 40s, mammography screening results in less absolute benefit and greater absolute risk for women 40 to 49. And without reading you all the details, their recommendations, or part of them, stated that clinicians should inform women 40 to 49 years of age about the potential benefits and harms of screening mammography. For women 40 to 49 years of age, clinicians should base screening mammogram decisions on benefits and harms of screening, as well as on the woman's preferences and breast cancer risk profile. You'll notice that after a period of 10 years from the time of the consensus panel, the College of Physicians came out with a statement that was almost a direct expression of what the panel had recommended in 1997. Now, in 2009, there's been a bit of a battle in England because of their great dissatisfaction about the nature of the brochures, the flyers that are described when they're trying to recruit women to come in for mammograms. And it says that they have promised to rewrite information flyers about mammography after advocates and experts complained in a letter to the London Times that none of the handouts, quote, comes close to telling the truth, overstating the benefits of screening and leaving out critical information about the harms. So we've now gone from 1987, 88, I think, to now to 2009. And still, there is no peace in the family. And there are still major disagreements on this issue. And so one is forced to say, well, why do we still have these continuing disagreements? Is there any way to quickly and easily resolve them? And one of the summary articles said, informed choice requires information about both benefits and harms. And that's something that many people find extremely difficult. Now, I'd like to tell you about the second example, which is called the LCAP program, the International Early Lung Cancer Action Program. And this was a study that had its major paper published in 2006. Survival of patients with stage 1 lung cancer detected on CT screening by that program. And the summary, it was a follow-up of almost 32,000 asymptomatic persons at risk for lung cancer, and they had low-dose CTs from 1993 through 2005, and then there were repeat screenings 7 to 18 months after the previous screening. Now you notice that this was considered by them. You see, this is considered to be the Early Lung Cancer Action Program. That does not reflect an attitude of investigating what is the correct answer to the question. When you initiate an action program, it has a very different connotation, at least to me. And the conclusion of the PI was that annual spiral CT screening can detect lung cancer that is curable. And here is the investigator, Dr. Claudia Henschke. And the New York Times said, when it comes to lung cancer, she doesn't believe in waiting. And here was her comment about her findings in the study. We believe this study provides compelling evidence that CT screening for lung cancer offers new hope for millions of people at risk for this disease and could dramatically reverse lung cancer death rate, says Dr. Henschke in a press statement. Well, what is the problem? Let's talk about some of the design and methodology issues with this study. And the problems were summarized in this paper in 2008, I believe. Here is a design of a randomized trial and the benefits of screening. If we're talking about a trial being done, then we have the eligible population and the randomization of the group. Whoops. And then there are screened and non-screened, and we follow up how many die from the disease in both groups. Now, there was only one little problem with her study. There was no randomization, and there was no control group. So what we ended up with was a case series, and what we don't know is how it would compare with a comparable population. So while she saw this as the solution for patients with lung cancer, there was really very little evidence to support that statement. Now, the other problem is seen in this slide. Here we have the usual time of diagnosis here on the left, light isn't too bright, and usual time of death on the right. In any screening program, even if the screening has no benefit whatsoever, you're going to end up with better survivorship. Why? Because you're making the diagnosis earlier, and so if you measure the interval from earlier diagnosis to usual time of death, it's going to be longer, even though the usual time of death has not changed. So this is a fundamental lesson in the area of screening, that cannot be changed, and that's inherent in screening. Now, 4 reasons why the case was not persuasive. It didn't include a control or comparison group. It lacked an unbiased outcome measure. The study didn't consider prior knowledge and did not address the harms of screening. Now, leaving the methodology for the moment, there was one more problem with the LCAP study. And that is, from this article from the New York Times, that the cigarette company paid for lung cancer. The payment was disguised under the name of a little-known charity called the Foundation for Lung Cancer Early Detection, Prevention, and Treatment, but it was basically supported by the Liggett Group, maker of Liggett Select, Eve, Grand Prix, Quest, and Pyramid cigarette brands. Now, that was in 2006 when that paper was published. And in 2008, a year and a half later, apparently under some pressure, Dr. Henschke and her colleagues wrote to report financial disclosures. This case, it's JAMA, but same with the New England Journal. And they wrote, "We wish to notify you and the JAMA readers of undisclosed potential conflicts of interest with respect to an article that we published in JAMA in 2006 and a letter to the editor we published in JAMA in 2007. Now you say, well, you know, people make mistakes and they can forget about some conflict here and there. So this is what they submitted for the conflicts of interest. And no paragraphs here, you see. So what we have is a very serious problem. And here are comments by the two journal editors, Dr. Drazen from the New England Journal. In the 7 years I've been here, we've never knowingly published anything supported by a cigarette maker. And at JAMA, Dr. Kathy DeAngelis said that she didn't know about her association with Liggett. I'd never publish a paper dealing with lung cancer from a person who had taken money from a tobacco company. And perhaps the most eloquent statement was made by Dr. Otis Brawley, who is now medical director of the American Cancer Society in Atlanta. And he said, if you're using blood money, you need to tell people. So there's more to the story, but I'm not going to talk about it. And what I wanted to show you, therefore, are these two examples that not only include methodology issues and attitudinal issues, but also ethical issues and many others. And these are the issues that arise in trying to make policy by translating epidemiologic data into policy making. Now, one of the biggest problems in using epidemiology for policy making is, as Barry said, the issue of uncertainty. In 1983, the National Research Council said, the dominant analytic difficulty in using risk assessment for decision making is pervasive uncertainty. And I think that this stays just as true today as it did 26 years ago. And our challenge is to try to deal with uncertainty. What do we do about it? And we have to accept the fact that it's there and deal with it. It's actually an integral part of science. And uncertainty is really what drives us to try to discover new things. If we felt certain about everything, there'd be no point in going back up to the labs upstairs. Scientific truth is often transient, and today's findings may be refuted tomorrow. And what we need is a testable hypothesis that we can either confirm or refute. Now, the Greco-Roman physician Galen, who had a very successful practice, he made this statement: all who drink of this treatment recover in a short time, except those whom it does not help, who all die. It's obvious, therefore, that it only fails in incurable cases. Now, that's a very tough argument to dispute. It has a theologic tone to it. And William Osler, the great internist who was at Hopkins for a while and at Oxford, said medicine is a science of uncertainty and an art of probability. And a well-known pathologist in his day, Dr. Charles Tidy, in 1877, said there's a scientific certainty which only the coward treats as uncertainty, and there is an uncertainty which only the boldness of ignorance ignores. Now, this quotation comes from a wonderful novel that I recommend for all of you for your leisure time. It's called Embers by a Hungarian novelist, Sándor Márai, and it was translated into English about 5 to 7 years ago, I think. And it tells the story of an elderly or an aging general who lives in his castle being taken care of by his nurse. And he's waiting for a visitor from his past, but you don't know what this person is going to represent or to bring. And he's very nervous. And so the nurse says, "What do you want from this man?" And he says, "The truth," said the general. And she replies, "You know it perfectly well." And he said, "I do not know it," he said loudly. "The truth is precisely what I don't know." She says, "But you know the facts," said the nurse sharply. "Facts are not the truth," retorted the general. "Facts are only one part of it." And I think we're in that situation in many of the decisions we have to make in epidemiology and in policy. Now, what are the sources of uncertainty in epidemiologic studies? There are three major sources, and I'm not going to go into details. There's the uncertainty resulting from the design of the study, uncertainty that results from the conduct and how the study was implemented, and then uncertainty resulting from how the data were presented and interpreted. And each of these we could spend quite a bit of time on, but these show you that there are major sources in what we as epidemiologists do that lead to the problem of uncertainty. Another source of uncertainty is reflected in the consensus conferences. One of the major sources of disagreement at the consensus conferences is that there is a dividing line between people who approach the problem presented on an individual or clinical basis and those who approach the problem on a population or public health basis. And in my view, I think one of the sad pieces of information is that there hasn't been much dialogue between the two groups. And there's not been, as far as I know, and Barry can correct me, there hasn't been a serious attempt to bring two groups together to see what can be found as a basis for rapprochement and can there be work together. Now, Robert Burns, the Scottish national poet, said there's no such uncertainty as a sure thing. We'll come back to that. And Daniel Boorstin, who wrote The Explorers and the Discoverers, said, the greatest obstacle to discovery is not ignorance, it's the illusion of knowledge. So these two slides, of course, are evidence that we have a poet on the one hand telling us about uncertainty, and we have a historian on the other telling us about uncertainty, and it's a reflection of the multidisciplinary nature of the beast. That it's not just an epidemiologic issue, but it requires many disciplines to contribute to our understanding and addressing it. Now, a book appeared last year by a neurologist who made an interesting statement. I don't know how good the evidence is to support it. Despite how certainty feels, it's neither a conscious choice nor even a thought process. Certainty and similar states of knowing what we know arise out of involuntary brain mechanisms that, like love or anger, function independently of reason. And obviously this would have a lot of implications for us in trying to address the issue if he turns out to be correct. And so I've tried to put together various diagrams to see how uncertainty fits into the decision-making process, but for reasons of time, I think I'm going to move along and not address that. Now, we have certain questions that arise about how people respond to uncertainty. How do scientists, including epidemiologists, deal with uncertainty? And there are several ways to do it. One is, of course, if you're statistically oriented, you can look for everything in confidence intervals. But it's not just a statistical issue here. A lot of it is conceptual. And one approach, of course, is to ignore it. But if you want to say, how do scientists deal, you have to look at who the scientist is, what's his background or her background, to what extent is there a willingness to take risks and to make pronouncements. How do policymakers deal with uncertainty? How do politicians deal with uncertainty? How does the public or how do target populations deal with uncertainty? And you could see in the first story I told you about mammography for women in the 40s, how several of these groups played a role in the decision or the reversal of decision. Now, this has gotten to be a very popular pastime, and here are 4 books published relatively recently. The second from the right is the book by Dr. Burton with his hypothesis. He's the neurologist I mentioned to you. How we decide. The one next to the left is The Illusion of Certainty. And then by Dr. Dan Ariely, Predictably Irrational. And there are many more. And I'm not talking about the books published by Daniel Kahneman, who won the Nobel Prize for his work on how people make decisions irrationally very often in economic situations. But he's done some brilliant experiments. And then we have people who have actually addressed the question, Should I Be Tested for Cancer? Know Your Chances. And these books are by Dr. Gilbert Welch and his colleagues, Dr. Steve Voloshin and Dr. Lisa Schwartz at Dartmouth. And so it's being applied to the issues primarily of diagnosis and screening in these volumes. Now, I'd like to take a few minutes and ask the question, what can the practicing physician learn about the individual patient from randomized trials? We have long maintained that randomized trials are our gold standard of truth, and that they, to a great extent, can reduce the issue of uncertainty. Well, this article appeared in the British Medical Journal a couple of years back. It's called Parachute Use to Prevent Death and Major Trauma Related to Gravitational Challenge, Systematic Review of Randomized Controlled Trials. This is the only photograph in the paper. Parachutes reduce the risk of injury after gravitational challenge, but their effectiveness has not been proved with randomized controlled trials. So that would be a real push, to reject it right offhand. And then the way the journal organizes the papers, there are little boxes, and one has to say what's already known about this topic, and then the next box is what did this paper contribute. So what's already known about this topic? Parachutes are widely used to prevent death and major injury after gravitational challenge. Parachute use is associated with adverse effects due to failure of the intervention and iatrogenic injury. Studies of free fall do not show 100% mortality. What the study adds, there are no randomized controlled trials of parachute use that have been undertaken, which is not entirely surprising. The basis for parachute use is purely observational, and its apparent efficacy could potentially be explained by a healthy cohort effect. And finally, individuals who insist that all interventions need to be validated by a randomized controlled trial need to come down to earth with a bump. Now, several years ago, in Lancet, Dr. David Mant published a paper, Can Randomized Trials Inform Clinical Decisions About Individual Patients? And he wrote, in part, the president of the UK Royal College of General Practitioners recently described evidence-based medicine as the new deity in clinical medicine and accused it of diminishing the importance of human relationships by ignoring the fact that clinical decisions in primary care often involve consideration of the unique problems and concerns of individual patients. This concern raises two questions. First, are the results of the trial generalizable, such that an individual patient will respond to the intervention in a similar way to trial participants? Second, is it possible to refine the statistical prediction of number needed to treat and number needed to harm based on the average outcome of the trial to give a more precise prediction of outcome for the individual patient? So let's look at this hypothetical study of two therapies, A and B, with the blue indicating patients who benefit and the white those who do not benefit. And clearly the proportion of those benefiting is greater in the group receiving therapy A than against those who receive therapy B. So therapy A would appear to be the better approach. Well, how much help does this provide for the poor physician? Here he has a patient in front of him. He knows about that graph on benefiting and not benefiting, but what doesn't he know? He doesn't know which part of the graph that patient comes from, that individual patient. Is this a patient who would have benefited had he been in the study, or no benefit? And similarly, for side effects, is this a patient who would have been in the minority who got side effects, or in the group that did not have side effects from the agent? Now, these are very important issues because these represent the guidance that a practitioner requires in prescribing for a patient. But in most reports of clinical trials, not enough information is provided to allow a practitioner to make that decision on what is the group that his patient would be in had he been in the trial. With that, I'd like to turn to some issues in teaching epidemiology. And I'd like to comment that what I'm going to express are my personal opinions without data, but they're in no way addressing either the program at Johns Hopkins or the program at NIH. In fact, I had a delightful experience meeting some superb fellows at lunch today here. But I'm going to share with you some of my thoughts. And the first is, how can the scientific and societal relevance of epidemiology be nurtured and expanded? And I believe that this is a major challenge that we face now. It's my feeling, if I summarize it, that we are sitting a little bit too much sitting on our laurels in terms of accomplishments in epidemiology training and not taking an open look and re-examining what we're doing. And we work on the assumption that all students are often the same, there should be uniform curriculum, and we don't ask the question, what are the desires of individual students and what direction are they going in? Now, one challenge we have is that when students work with populations, we need them to keep in mind that these populations are comprised of people and their families. So a student who looks at a table often doesn't remember that the numbers in that table represent human beings who are anxious, who are suffering, who are under tremendous amounts of stress, and whose disease is going to have a major impact on children, on any kind of relative, and even on friends. But the challenge is, how do we get a student who's doing epidemiology to stop the analyses and ask a question about the individuals in the table? Now, Osler, whom I mentioned to you before, wrote, "It's more important to know what sort of patient has a disease than to know what sort of a disease a patient has." And John Bailey, who wrote a wonderful book, Elegy for Iris, for his wife Iris Murdoch, who died with Alzheimer's disease, and he recites in the book that after Iris had died, he met a woman whose husband had also died from Alzheimer's disease, and she indicated she would like to sit down and chat with him about their experiences, their common experience. And he resisted it and said, "One needs very much to feel that the unique individuality of one's spouse has not been lost in the common symptoms of a clinical condition." And writing in Academic Medicine a decade ago, Mark Tonelli said, "Under the current understanding of evidence-based medicine, the individuality of patients tends to be devalued. The focus of clinical practice is subtly shifted away from the care of individuals toward the care of populations, and the complex nature of sound clinical judgment is not fully appreciated. Evidence-based medicine currently fails to provide an adequate account of optimal medical practice." And now from a different source, when you take an idea or a concept and turn it into an abstraction, that opens the way to take human beings and turn them also into abstractions, like the numbers in a table. When human beings become abstractions, what is left? So maybe this is the lesson that we could learn. We must not see any person as an abstraction. Instead, we must see in every person a universe with its own secrets, its own treasures, its own sources of anguish, and with some measures of triumph. Now, I'd like to raise with you the question, can and should epidemiology be taught in isolation from public health? It is my belief that the richness of epidemiology and its potential is expressed only by being taught with public health. That is the objective of epidemiologic studies. Now, many of us get a great thrill out of new methodologic steps and so on, but the public at large doesn't have the same excitement about methodologic advances and statistical advances that we may get. And so the question is, should it be taught in isolation? And my response, and some of you may disagree, and I hope we'll hear about it, but my response is that it should not be taught in isolation. Now, excellent training in methodology is necessary, but I do not believe it's sufficient if the full potential and promise of epidemiology is to be realized. And as far as the role of creativity in epidemiology, this is a picture of I. Rabi, the Nobel Prize-winning physicist, who spent much of his life on the faculty of Columbia University. And he was asked, after he won the Nobel Prize, what was the major factor that led you into science and to having a successful career? And he replied, it was my mother. And they said, your mother, well, what did she have to do with it? He said, well, I went to kindergarten, and the first day in kindergarten, and I had a lot of Jewish kids with me in kindergarten, and they went home, and their mothers say, what did you learn in kindergarten today? And my mother said to me, Izzy, did you ask any good questions today? And that was his guiding principle throughout his life. And I think that it is a major issue, the asking of good questions, for all our trainees. Now, it's not simple, by the way. It's not simple because there are a number of obstacles. In my experience, many young trainees are hesitant to phrase their research in the light of a question. There may be discussion of an association between factors, but not an explicit hypothesis. Often when the association is even proposed, we're not told which direction the association goes in. And I think there is a great fear about being found wrong. And that is terrible because I think young people are the ones who have to be willing to take risks and to be found wrong, if so. So I'm going to leave that because my time is rapidly approaching or has passed, but I'd also like to offer for your consideration the differences that I have seen in mentoring between the bench sciences and epidemiology. It's bad to generalize for either, but if we look at the mentoring in bench sciences, the trainee and mentor maybe, but the trainee carries out an experiment one day, maybe 2 days, then meets with the mentor, they look over the data. It's a turning point of what the next question should be or what the next experimental design should be. Mentoring in epidemiology is very different from that. First of all, the studies take years to complete. So you don't have a meeting every second day to look over the data because the data haven't come in that period of time. In addition, or as a result, I should say, there is a problem because there's therefore a lower frequency of contact between the mentor and the mentee in epidemiology than in the bench lab. And this raises a real question of what do we expect from the mentor in an epidemiologic relationship. And it's something that I don't think we have fully developed at this time. And so what do we need to provide for our students and our fellows so that graduates in epidemiology will be responsive to public health needs? Now, I think one thing is needed is breadth, B-R-E-A-D-T-H, a breadth of vistas. It's unfortunate, I think, but I detect a greater narrowness among many students than in the past, and part of it is not their fault. For example, when I was their age, I wasn't alone, but a lot of the people I trained with, we would go in the afternoon once a week to the medical library and go to the shelf where you had new journals that were received and just sit and flip the pages looking for something of interest. Well, that doesn't happen anymore. First of all, you go and you do a direct download of the one paper you're interested in. You never see the other papers in that issue in general. Secondly, you can't even do it if you want to because they don't get the hard copies of the journals anymore. So I went to the Hopkins shelf just to see if I was right, and for this week they had 2 issues of different journals that had come in. It used to be 40, 50 issues of a journal, and there's nothing like flipping the pages to get stimulated by an area outside your own that makes you say, does this have any relevance to what I'm doing, or isn't this interesting, even though it's not something I'm working on right now. And I think there's a need to be able to broaden the students' vistas. One way is that the students should, part of their training, I believe, should be with multidisciplinary groups. And they should address solving public health problems in school, but with people they're going to deal with in real life. Economists, health administrators, sociologists, psychologists, all these things play a role, whether it's uncertainty or other problems. Last week I was told about a student who graduated our department this year, and she was a very good student, and she's gotten a wonderful job at another university. And she told a colleague of ours that what drew her into epidemiology was that it was part of public health and is a helping profession. And now she's worried that she knows she has a good job, but she's going to be sitting in front of a computer monitor with no human contact of people who might receive any kind of helping service from her. And she was very distressed by this. Now, maybe her expectations were unreal, but I think one issue is that we don't explore the individual expectations of the students that come into our programs very often, and we assume that they've all been born with a desire to become epidemiologists, and that may or may not be true. So what should we be doing? I think there are a few possibilities. We should be asking, what positions are we training students for? What are their individual aspirations? What are the types of satisfactions they hope for? What do they hope to accomplish in their lives? And how can a training program accommodate such heterogeneous groups of students, especially when people have such different ways of learning? And so with that, I'm leaving these questions to pose for you, and I think we should be very proud of the accomplishments of epidemiology, but that's not an excuse for not doing a careful, introspective self-examination and planning for the future. Thank you.
Do you think, as Mark Klebanoff from NICHD, hello, as someone who was your student in 1982 and then came back to school for a year 25 years later, I was just wondering, having looked at this now, do you think we teach more methods because it's easier to teach methods than to teach perspective?
My guess is, I don't know how to measure it, Mark, but my guess is that there is more of an emphasis on methodology, particularly on statistical methodology, now than there was, 20 years ago, whatever number of years. And I think we've improved by that, but I'm not sure it solves some of the deeper problems in the discipline today. Yes?
Well, you described the epidemiology
A little louder, it's hard to hear you.
You described the breast cancer issue and the lung cancer issues. So what is your personal opinion? And also recently similar uncertainty came out from the prostate cancer studies that multiple screening is not necessary. So the uncertainty is always there. And so what is your personal opinion?
Well, let me just take the first one on the breast cancer. I mean, the current expressions that I showed you for 2007 and 2009 are really re-expressing the conclusions of the consensus panel in 1997. My point is just that there hasn't been a settling down and a clarification but it still foams and simmers, and people are not willing to accept. Now, there are a lot of reasons. We could go into the consensus panel issue, but I won't do it this afternoon. But the question is, have we moved closer to a resolution of conflicts in this? And I'm not sure.
So again, it is more uncertainty.
Okay, thank you.
Well, first of all, congratulations on winning this award and giving an outstanding lecture. As related to this talk, one of the, in my opinion, most interesting policy debates right now has to do with the Gardasil HPV vaccine and the proposal to make it a mandatory vaccination in different states or across the country. And I find it interesting because it relates to a lot of what you're talking about, both examining the efficacy of the actual vaccine, but also in making it a mandatory vaccination, the economic issues for people, and of course the political issues as related to HPV, sexual abstinence, all of that. I was wondering if you could weigh in on this particular debate or talk more generally about how you would approach these kinds of proposals as related to what you discussed.
Let me just comment, and it may be an unreasonable comment, that to the best of my knowledge, we do not have evidence that the HPV vaccine prevents cervical cancer. So it's a little hard to understand how people want a mandatory vaccination program when the endpoint has never been demonstrated. It's too soon anyway. I mean, there are a lot of reasons why it hasn't been demonstrated, but the fact is we really don't know. And if you say, well, because it's type 16 and 18, and you're going to, get rid of those types, but a lot of people are very concerned that other types will come in to displace them. And so it's not clear at all that cervical cancer rates would necessarily go down. So I don't think the last word is in, and then one has to ask the question, well, why was there this burning urge to do it when we do have Pap smears anyway? It's not a totally neglected disease. And part of it is the drug company behavior, which I think was inexcusable in pushing on the vaccine. Want this?
Leon, thank you so much for really a wonderful and thought-provoking talk. And as so often happens, I'm going to guess that there are many people that are going to want to talk with you one-on-one out in the lobby. Please join us for any one-on-one discussions with Leon. And thank you very much for coming, and congratulations.